they're placed here for like 2 months. So you really get good at this stuff. So, even though you did a slight rotation, now their rotation, one is just between 10 and area in cardiac care units. And then their last phase is, I think obstetrics, they don't come down and no, Kent, they're doing the obstetrics at Kent, they're doing the cardiac care crisis stuff in Maryland. So they're there, so they're just doing 2 months and 2 months. Because it's a real in-depth of what you're doing. So think about it, what we're talking about is still the #1 killer in the country. Over all the cancers, all the life, #1 killer still is. So, as we get to this now, so the slide we ended, so up to this point we talked about just electrical activity in the heart. So now we're showing you where it gets it from. All right. So we know the pacemaker cells and the actual muscle cells will work on their own. You don't need this system to make it work. But what is this system going to do? Well, this system, pretty much, when we're on this blue one, this would be known as vagal stimulation or vagal system. This is primarily where we're in on. That kind of keeps the heart at 75 beats a minute. Rough. You know, rough. That's the estimate they use. The book like 70. Or use 75. Well, really, optimal, you'd want that heart rate to be probably between 65 to 70. So we're not wearing it out. Someone with a resting heart rate of 68, 67, that's pretty good. True long distance runners probably have a resting heart rate around 60, 58 to 60. So what does that mean? The heart has a lot of resting. So it's really good time to regenerate itself, which is good, because it's very healthy, okay? So one of the things you're gonna see, the sympathetic system not only hits the SA and AP nodes, but actually respond deep into the cardiac muscle with norepinephrine, causing a significant change in how hard this tissue is going to react. So it will affect volumetric pressure in the heart, big time sympathetic system. So the point is, if you're chronically stressed, it's just inside because it's the end of the world of this class. Again, you have to live in chronically stress. So what's going to happen? Nothing. Is it going to eventually create cardiac disease? Maybe. I'm sure. We'll remember something from next door. I'm good for leaving crap all over the place. So think about it. Because pretty much we trigger the sympathetic system through nervousness to the brain and through hormone. The chronic stressed person finally triggers it through hormone change. And then that's not a good situation because now it doesn't show off. So think about the walls of that heart constantly. Your blood pressure is high. And this is what we're going to go to and show you this, how by understanding these pressure gradients, how we're going to destroy the heart. We're going to learn that the left ventricle has to beat against a gradient at least 80 millimeters of mercury to get that blood to get out and to get into the aorta. On the right side, it's only going to push against 10 to get it into the pulmonary. So there's a lot less stress on the right than the left. And you're going to see that. You don't understand that. Do you understand up to now the two graphs we did? But this way you can jump around back and forth. I want to make sure you understand the two graphs that we showed the other day. Because if you got that, you're halfway there. Understand? So you're halfway there. So let's go back before this. So let's look at this. This graph is showing you electrical activity of the pacemaker. This is the patient. This is the electrical part of the heart, the wiring. This is not the myocardial tissue. There's a nut showing you contraction. And few things you're going to realize when you do the lab about the ions. Anytime I throw potassium in there, I'm not going to destroy them. I'm shutting it down. When I use sodium and calcium, sodium will intensify it, but calcium really intensifies it. Because with calcium, that actually will go deep into the cardiac muscle and make those cross bridges even stronger. So it really enhances heart rate. That's what digitalis does. It plays with the calcium. So then you're going to start saying, wow, if I use a drug that is a calcium channel blocker, I weaken heart rate. If I use a beta blocker, I weaken heart rate. So it's going to help you understand the meds that you're going to be reading about, injecting and putting in people as RNs. That's why I'm doing it. I'm trying to reduce the load on the heart. So this is just the first aspect. So we know that's sodium, then this is calcium, and then this is potassium. But notice there's no respite. It just goes right back. It doesn't stop. So this is showing you the pacemaker. The other one, I don't know if we got there yet. We did all this crap, right? And this summarizes the whole thing, how it works. How long did it take to get from here to here? 22. The total cardiac cycle takes 8 seconds. Moving blood from when they can trace blood from vena cava to aorta, that's an 8-second frequency. 0.8 seconds, not 8 seconds, 0.8 seconds. And so you move a lot of blood. 5.5 liters per minute is what the heart's moving. It's a lot of blood. Why? Because every piece of your body has to get oxygen. Your little toe, your little finger, that has to get oxygenated every time that heart beats per minute. So that's why I got to move that much blood. So we do move a lot of volume. So you realize that over and over and over again. So this is why this is so this is just showing you the electrical wiring of the heart. Then from there we go in and we get this the junction rhythm, right? So what happens here? You would see, I want to show you the tracings. So in other words, I have no SA node. None. It's not working. So I have no P waves when I look at an EKG tracer. It's ventricular. So that's a wonderful setup. So I have no force of the atria pushing blood in. It's just going in its own little rate, which is not a good situation, okay? So, and then we realize we get these extrasystole beats because of too much of this. Or the hyper person, the stressed out person. A lot of times you see pre-ventricular contraction, especially when you put someone on a treadmill, like cardiologists who do that, and you know, do a stress test on the heart, and they want to get that heart up to about 180 beats a minute, keep it there for 5 minutes, and see what the heart does under that much demand. Then, how fast does the heart bring itself back to normal? And it should do that in a certain time frame. There's where you can throw the PVCs. If you throw like 3, 4 in there per minute, that's not a big deal. The body will compensate that. But if it's more frequent, well then, you know, there's a problem here with our firing mechanism. It's not doing it right to bring it back to rest. So that's stuff that they look for, okay? So then the heart log. So we're going to show you this too. So in other words, when we lose 2 P waves per cycle, we're going to see, well, that's probably second degree. An elongation in my P to Q wave is probably early signs of heart block. When the P wave and the Q waves are beating when the hell they feel like it, that would be a true 3rd degree block. And we're going to show you this on the traces. And pretty much, you can simplify it like that for testing. It isn't that simple in the real world, unfortunately. To figure that out. So that's why you have people who do nothing but read tracings. The electrocardiophysiologist, that's all they do. And then they know exactly by looking at what's going on. One's the Holter monitor. You put this thing on you for so many hours a day, and you wear it, and they see what's happening to you for the time frame. Because something's going on that we're not seeing. Well, every night I feel like, just like, out I go. Well, now we're going to see, well, what's the heart doing? So it doesn't miss anything. Compared to that tracing done for like a couple of minutes, that's just telling me at that time frame, right now, the heart's working fine. But an hour from now, it can stop. I've known people come home from the cardiologist, drop dead in the driveway, and everything was fine at the cardiologist's office. So it's just, is it my time? So then we have the accelerated centers and the inhibitory. So the inhibitory centers is the vagus, the acceleratory centers are going to be the actual sympathetic trunk, okay? So here we are with that picture again. So this we saw when we did the autonomic nervous system at the end of last semester. You saw this picture. It showed you something similar to this. And you figure out which one is vagus and which one. So vagus, what we're going to realize, even when we get respiratory, we get GI tract, everything to the proximal third of the colon is under vagal control. Sacral control doesn't come into the transverse descending colon, rectum, bladder, urine. That's under that control of the parasympathetic system. So we learned cranial sacral is the parasympathetic system. Thoracolumbar is the sympathetic system. All right? And they inhibit one another. When one turns on, it shuts the other one off. And that's how they work. They're opposite effects. And the heart constantly kind of goes back and forth with it through the day. But 80% of the day, it's in vagal, which is normal sinus rhythm. And you want that. You don't want to burn this thing out. This is the stress one. That's the normal one. So the rest of digest, the, fight, flight. So as new material comes into you and it looks really hard, you turn that on over here. As we go. But as the material starts making sense, you start to relax, and you go back to your vagal. Okay? So it's going to go back and forth. Learn to stay in the vagal nerve, because you learn that. When you stress, your brain shuts off. And you absorb nothing I'm saying, nothing you're reading. When you relax it, and it's only be certain times of the day where you stay in that relaxed state. That's when you should do your study. Not because I have to do it 3 hours every night. Well, if you're all stressed out when you're going to sit down and do this, guess what? What do you get out of it? Nothing. Nothing whatsoever, right? Nothing. You just looked at pages and nothing went in your head. But if I do it like when I first get up in the morning at 4:30, and I look at it till 6:30, man, I absorb so much. Well, then that's when you do it. There's no set time in the day, which is the right or wrong time to study. I get the most out of reading these PowerPoints is like 7 in the morning to like 8:30, 9 o'clock to my first class. I'm breaking them apart and taking notes off to make it make sense when I present it. Because I first look at it and say, like Benson and I, we look at them together and we think, you're going to get this. And there was a lot more that you're not seeing that I just threw out because I know you're not going to get it. I'm not even going to attempt to talk about it. The last time I really read tracings and stuff on patients was 39 years ago when I was an intern. That's not what I practiced. Last time I taught this formally in this setting, 7 years ago. When I was doing phys. So it's new for me too again. All right? But I do know it, so it comes to me quicker than it's going to come to you guys. But the point is, not that I don't understand when I read it, how do I make you understand it? In layman's terms. That's the important stuff. You getting it. Not me just reading it back to you, well, what is it? Blah, 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 blah. Now, what you're seeing here is the muscle tissue contract. It's a different graph. So know this one, know that graph, know this graph. If you see it on test 1, then you know what the hell it is. So I'm telling you, it's going to be there. You don't know it, shame on you, because I told you. I didn't trick you. I said, oh, don't worry about that. Bang, there it is on the test. I don't do that to you. If we skip it, I don't ask.
Where you been all my life?
Hiding in the closet. Hiding from these people in the front of you. They keep finding me. So, the same things are going on. This depolarization, look, this is all what? Sodium. Now, see this plateau line, how it slowly plateaus down to end? That's the calcium channels. They will be nice and slow, and they cause this nice contraction. Then, at a point, as the hump starts coming down, we go into potassium going in, negative the membrane, and we shut it down. And because of this, you cannot put this muscle into tetany, because that's not how skeletal muscle looks like this, just like how the muscle contracts, it looks like this. But what did it do? Do you see any, some of you have done the, even though you hit it with electricity, the heart just stops. It doesn't do anything when you hit it with electricity. Where if I hit your skeletal muscle with electricity, it's doing this, over I go. But the cardiac muscle doesn't do that. It just says, okay, I stop. When you're done doing it, it'll turn back on. You know? So that's why you can't tell. So when I hit you with electricity or a different type of botulism, hit you with that, yeah, I can turn that muscle into technique because you have trepid, stair step. It finally goes, stays there, it goes into complete tetany, right? Or fused tetany, and then finally it just goes. Why? I fatigued it. How did I fatigue it? I depleted all the calcium and I depleted all the ATP. Well, because the way this is designed, you can't fatigue it. Because if you could fatigue it, you would die right away. So I can't fatigue it. The only drawback is it always needs oxygen, where skeletal doesn't. This does. So it's a whole different plateau. And there's no true resting membrane potential. Because it constantly fires. It's a constant. Where skeletal muscle won't do anything until you call on it. So it just sits there waiting like that. Okay, you got it? With this is always like, it's like 100% can't stay still. There it is. It's the ADH of muscles. Alright, so there you go. So, know that one, and know this one. Understand what's happening. There'll be verbiage about it, and there'll be pictures. Identify it. Might be boom, boom, boom. What tracing is it? Because that won't be there. You know, we take that away. If I put pacemaker, I know where it is. So it's, and they could ask, well, put the two things side by side. Which one is representing pacemaker cells contracting? Which one is representing cardiac cells contracting? The actual muscle cells. So I'm showing you how to study for. And by this point, you should know how to study this stuff. You train now. I should see a better student in you than I did in semester 1. Because you train. You know what I'm saying? You train. You know how to do this material, how to digest it. Some were awesome and became tutors. Some, one. Everybody else I recommended, no. Well, you couldn't, though. There was a reason why.
Yeah, I couldn't because of the FAFSA stuff that you have to do.
Oh, is that why? Chris, you told me that. So let's go back to that picture now. So we did all this wonderful stuff. Could you label that? Might be there. It's worth knowing it. How about I throw a nice bonus on there, trace the drop of blood through the heart, from the vena cava to the aorta. Named in the landmarks it's passing through as it goes. Maybe that could be 10-point bonus at the end. Because if I understand how the blood moves through it, I know all the parts. Now we're just working on how does it work. So we're talking about one electrical, the wiring, then the muscles, and then how does it how does it do things? That's what we're showing you. We're just taking a pump all apart. Oh, here's this thing that does this. Then the wire comes in and hits that, and then, oh, okay. That's what I'm doing with it. We're just taking it apart and breaking it down. So you understand why it can break down. Then we go and show you the examples at the end, the homeostatic imbalances. What can make this system not work right? So that's the aspect you're going to get when you get to your clinical. Why isn't it working right? But if you don't understand the normal, they're talking language, you have no idea what they're talking about. This foundation is so important, people. I can't get that point across to you. You know your anatomy, you know your physiology, everything else is a breeze. Because you know it already. Now you're applying it. And that becomes an how do I apply it? And you will learn that. That's why they put you through these 4 semesters of rotations. They're teaching you how to apply this. You're not learning that much new, but you're learning how to do it now. That becomes the art of practice. So there's a science to nursing, and there's an art to nursing. That's why it's art and science, yes.
I do love what I'm learning from these two courses, but this is a question for me. Why this is a prerequisite for dental hygienist?
For who?
Dental hygienist.
The torching.
What?
The torching. I can see the physiology for hygienists, because you will encounter people with conditions, and you might represent looking in the mouth. All right. Did I think you needed to go so much detail for the anatomy other than the head and neck? No. Because when you go off to dental school, you just do head and neck anatomy. They don't do anything else. And you'll take systemic pathologists to understand systems. But some of it is you need this total foundation in case you go forward.
I love it.
Hygienists eventually, like in certain states, are already pushing these bills. Can extract teeth, can do everything the dentist can do as long as the dentist is somewhere in the state. That's what we call it, because they're not even there at the time they're doing shit. We do that with our staff too, they do stuff. And, you know, you get a trust in someone, you know they can do it, then you let them do it. But the point is, you might encounter someone. Why is somebody throws an original while you're doing a dental procedure? Would you recognize that?
You have to be able to.
That's what you learn.
At first, the same thing as well. I'm like, this is so pointless. Why am I taking
If I'm injecting a Novocaine into the gut line,
You need to know what they're going to.
right, and if it hits something else and goes down one man heart
Everything
condition,
could go to the left.
I can like,
That's
let me get a little more anywhere it comes, so I kill my way. I tried, they died. That can't talk. That's what the mafia says, right? That can't talk. Oh, I saw you shoot him. No, you didn't anymore, you're not here, you're gone.
It's a blessing, doctor.
Just,
It's in your class.
kill them fast, that's it. Years ago when I worked as an embalmer, you go, look, we need the business, if he's still alive, embalm fast. That was their slogan, embalm fast. All right. Middle of the night, we too tired to recognize anyways, they're still alive. So. Whatever, back to this. Okay, so when you affect this conduction system, you end up what they call arrhythmias. Meaning, I'm without rhythm. Right? Some people dance that way. They think they can dance, but they can't. Like on Seinfeld when Elaine would dance. Yeah. But no, some people can't. They have no rhythm. There you go. Well, the heart loses rhythm, that creates problems. And someone, you get this important atrial ventricle. So one of them is going to start moving quick. So it's going to go into this rapid irregular contraction, it's a fibrillation. And what's the most common thing you hear about? AFib. Most things you will encounter someday will be CHF and AFib. Most elderly eventually end up with that. I'll give you physical therapists, occupational therapists, you're in nursing homes, man. We have these people recognize the signs because they're going to drop in front of you. I got someone with CHF. I can't rehab that hot through exercise because the tissue is damaged and scarred. Just let them learn how to work within their ADL, activities of daily living, to make themselves sufficient. So you do need this, PTOT. Hygienists recognize the signs. You're going to approach this patient differently. True dental officers that do the right thing actually do blood pressure on their patients too. And do a full head and neck exam of all the nose and looking in and touching. Because you can find cancer there. That could be missed by the family doctor because you're a better expert at looking in there. So hygienists are really good at looking in there. But one of mine, she's really good. And when she looks at, well, that tooth's got looks like a fracture. Well, it was. But it was getting to the point where they had to just grind it down and put a cap. Because it would hurt every time something hit it, shoot. The tooth would expand itself. So yeah, she knew what she was doing. She hit it right on the head. It was 2 months later, boing. I said, you know what? I went in, I said, yeah, just take care of this. And they did. So you understand? But look what happens. Death. So what was the final thing? When's the person dead? I'm going to go out and go. And that should be an heavy death. Brain stops. Man, we're still alive as far as the brain, but heart stops. That's an important thing, this heart. And all of you have thrown a PVC here and there. When you're home, you move, I was like, I feel my heart. It's like weird. Okay, we're back to normal. We want to just roll over now. And that happens. So if I hit you with a defibrillator, it interrupts cardiac twitching, giving heart a clean slate to stop that. So that sentence is telling you why it can't. Because what is defibrillation? Hitting you with a high dose of electricity. The heart stops. Skeletal muscle does this. Goes in apoptosis, locks up. Don't stop. The calcium bridges just lock up. Here, everything goes like this. And hopefully when I turn back on, it goes back to normal. I'm resetting the computer. So it's a whole different way of contracting from what you were taught last semester. So that tells you everything. So when you break these things down, it's telling you. I give it a clean slate, a fresh stop. Punt the ball, let's start again. They got a strap down there, punt the ball away. So then other weird things happen. We get these ectopic, like we said, focuses, and you get extrasystole where it's not relaxing. It throws an extra beat in there. Because the systolic part of the heart, it's contracted. Diastolic part, it's relaxed. So you have EDS, EDS and diastolic systole, and then diastolic volume and systolic volume. In other words, what's the volume in the heart when it's on the full contraction? What's the volume in the heart when it's relaxed? And those are important phases for how much percentage of output comes out of the heart with each beat. And different damage to the walls of the heart will affect that. And then you know what medications do I use to fix this. Okay? So that's the stuff you're going to deal with. So, reach the ventral passage to the AV node. If AV node is defective, it may cause heart block. So when you're talking about a heart block, that's not a blood thing, that's a wiring thing. There's no communication between SA and AV. The communication is weak. Now, damage due to ischemia could have caused that. Or birth defects, drugs, cocaine. I'd like to Well, good for you. So you sniff it just right, where you go right out with a feeling, you don't have to worry about it anymore. So partial block, no impulses, total block. So there's a lot that are in between these two. So, when you're treating patients, so even though you use certain meds that should stay local, sometimes they can slightly get systemic. The cane groups, they're going to affect this. So that's why the hygienist has to learn this nonsense. So I hope that explains it, okay? So when it gets bad enough, we put the pacemaker in. Now the defibrillator, this is not fibrillation. So some people have both. I'm blocked and I get atrial fib. I gotta put both in there. So they have the defibrillator here and the thing over here, and they walk around like, you know? So that's why when you were kissing that guy, you made such a spark as the defibrillator. Just saying. I felt the spark. Oh, I do have a defibrillator. Oh, okay, that explains it. Did you miss this stuff in January over brain? No. So we have two centers in the brain. One that's going to accelerate, one that's going to inhibit. So parasympathetic vagal stem is going to decrease. So if someone's got a real rapid heartbeat, and I'm trying to get them to relax and calm down, stimulate the vagus. Play with the nerves right here, passing by, play with that, stimulate it. If I can stimulate that vagal stimulation, I'm going to slow your heart rate down. If the heart rate's, and I want a sympathetic stimulation, stop banging on their back, right in this area here. Stimulate the damn sacral, the sympathetic plexus, see if I can get it to stimulate. And that was the research I did when I was getting my doctorate. Now I'm kind of just figured a little research thing. And you gotta put a paper together and everything on research. I did that for my year while I intern. I mean, it's not like we get stuck with this. We have all the EKGs, pre and post manipulation, see what they look like, pre and post blood pressure, see what they look like, compare them all. So we did like about 500 patients. And see the change. If I manipulate here, what would I get? I manipulate here, what would I get? So can I treat these diseases through doing this? That's what we're trying to show an outcome. Can you, without using heavy meds, can I treat it through natural ways of treating it? So one's going to stimulate, one's going to inhibit. So this, look how far down it goes, right to the coronary artery. So you're going to blow those things right, and there's your picture again. So we slowly work back to this picture. So one was the pacemaker. Fine. And it goes from here to here, and that takes 0.22. And where was the 1/10 block, 0.1 block? Where does that happen? Between what block? SA to AV. And you need that, because you're going to realize, well, we got to totally empty out these atria into that ventricle. And then we're going to learn why the valves close and how do they open. It's all pressure gradients. You're going to learn all that. And you're going to learn when they don't work right, a little more detail about the murmur. To make it make more sense to you, we just briefly did it with the anatomy. Now we're going to totally show it to you with the physiology. Okay? So, here we are. There's your other graph to know. What am I reflecting in this graph? Well, this is the actual contraction. That's the muscle. That's the muscle contracting. The other one is the firing of tissues within the muscle. What is happening? Remember? When we had a fire in the muscle, the first thing that opened when the acetylcholine reached the receptors on the muscle was a sodium channel open. And you don't see that. So that's when it was slowly building up to make the contraction. Right? You don't see that. And finally, we get to the endoplasmic reticulum, and boom, the calcium blows out. And when that calcium blows out, now we start seeing the bridging forming. And we actually see the true cross breeding, which was the power stroke of the muscle, because we converted the isotroponin to troponin to make the head sticky and grab it and yank the axonal myosin together. That's the power stroke. And then the third phase was releasing it. Well, kind of same thing here. Because the heart does have cross bridging too, and certain drugs will enhance that cross, like, you know, hitting in your digitalis with calcium, the calcium channel opener, it's going to make it beat with much more force, the heart digitalis. Give me a better contraction. Okay, so that's it right there. But this is what's happening at the chemical level during that contraction. And it's just going to repeat this again. It's not going to sit there waiting, the resting membrane potential. You really don't have that true same potential like you do with skeletal muscle. All right, because this has to constantly fire. So we go into what we call ECG or EKG, and this is a typical 12 lead because that's the most accurate. And look, he's usually in this class, when he came to yesterday's class, he's a paramedic, and he reads these things all the time. And it's just time, because each square represents time. And if you have more squares than you should, then we have a block. Explained it very simple to the class. Because I said, why don't you explain, because you see this all the time. You're dealing with this, 4 days a week. The rest of us are not. Explain it. Because there is a rule you use and measure, but that's when you're really doing a true diagnostic workup. But in this case here, no, this is going to be quick. And this little square on the paper, the tracing, represents time. And if things don't happen within that time they're supposed to, then there's a problem, Bruce. Spaceship's not making it back home. It's going to stay up there in heaven. Okay, so the P wave. So the most thing you really need to get in your head is this. What's happening in each phase of this? So during my P wave, which would be your first wave, I depolarize the SA node in the atrium. It's depolarized. That means it's contracted. When I get to the QRS complex, the ventricle depolarizes and the atrium repolarizes. It has to. Then I get to the T wave, the ventricle repolarizes, then we start all over again. Then the segments between the P and the R. So from here to there, this peak to that peak. That's the beginning of atrial excitation, the beginning of ventricular excitation. When I'm at the peak, it's excited. The right person walked by, you got excited. There you go. Like your heart goes, whoa. It's a muscle. ST segment. So S to T. So you get the Q, right? Q, R, S to T. So with T, the entire ventricular myocardium is depolarized before I get to the peak of my T. Then I have the QT segment. And we'll show you this when we look at the picture of it. The beginning of ventricular depolarization is the beginning of it, right? Through the ventricle repolarization. So it's the whole ventricle, from depolarization to repolarization. And they look at these segments because there's where you're going to find the issue. There they are. There's your traces. So that's depolarized, depolarized. So this interval here, P to R, means this depolarized and repolarized before there. Understand? S to T, this was full depolarized to repolarizing here. So from this point to that point is the whole ventricular segment. So when I get a lengthening in this here, there's a problem between the SA and the AV. Because the AV node to the bundle branches is that connection of the atria to the ventricle. So there's a problem. When I distort this thing here, that it doesn't goes too high, it goes too low, it's usually there's a problem with ischemic attack to the heart. The heart's been damaged, like a myocardial infarction. So there's different things. This thing widens itself, the ventricles are enlarged. So there's things they look at other than just this. But all you need to know is what the normal looks like. Because anything else is abnormal. That's why you have cardiology people. They deal with it. So you're looking at the tracer, oh, this thing isn't right. Call the doctor and come in, get a problem. you'll recognize and you'll start knowing what it is because you do it every day of your life. You get nurses that work at ICU, critical cardiac care units, they're gonna know this shit. They deal with it every day. Emergency room nurses, they're gonna know this stuff. The one on the nursing home floor, well, you get complacent. If you're not keeping up with stuff. Because your patient's supposed to die. That's why they're there. That's the waiting room to the cemetery. The nursing home. Well, not many graduate from there and get out. You know, so you're going to think the way you're working, what you're working in a hospital, so I can make a mistake, don't make a difference anyway, I'm killing them anyway, slowly. Whoop, they're going to do too much, oh well. Sounds awful, but it's true. So I make a little mistake in bomb, who's going to know? You're going to tell them? Oh, okay, so you have to worry about it. So now it's showing you each phase of what's happening in your heart. In the next picture, it's just the same thing, just showing it to you differently. And your lab book has this, your lab book has that. So when you're doing your experiment this week using the PhysioX, take your lab book and open up to the electroactivity of the heart. Even though you're not using BioPack, you're still looking at a heart. So it does help explain to you what you're doing and why you're doing it. And what's good about by the time you're done with it, if you do it properly, so you're going to have a monkey in there running it, it doesn't make a difference. You're going to know what you did and why you did it. If you do it, not just to run through it, to get done, get the hell out of here, we don't want to be here, because it's Friday, it's the weekend. No, get there so I learn to reinforce this. Understand? All right, you understand? My complaint is in the front. Right here. There's one more, the other one went. But it's showing you, there's the SA node, there's the HO, right? HOD pull was initiated by SA node, causes the P wave. So it's telling you why it happened. Because what is it seeing? What does the ECG really see? It's not seeing contraction. It's not seeing blood flow. It's literally seeing what electrically is happening. When I do the sonography of the heart, which is an echo, now I'm seeing the blood flow. So when you combine two, I see the electrical activity and the actual output of what's going on with each chamber, each valve, because they actually look at that and they time it. And that's why you end up stopping it, because they're recording. Anybody going into that stuff here? No? Going into that? No? Yeah, that's what you're doing? So you're like, Jen, this is the tutor I had a few semesters ago. She's in her final semester now, sonography. And that's what she's doing with the heart. So she's in a rotation in the hospital now doing that for me. That's your final phase. It's like, for real, you will touch people. And the doctor will come in the room and ask you what you're doing and why you're doing it. I guess I don't know. They told me to. That's not the answer they're looking for. Did you see a change through the night in this patient, through the afternoon, in the urine output? And what do you think why? What's going on? So you're going to get asked stuff like that when you're on your rotations. And it's nice to look stupid in front of everybody else with. That's why you go behind the back corner of the room, stand behind the bed. Oh, I'm the CNA, don't ask me. You get what I'm saying? You guys going to hygienists, you ever go into the clinic there? See what they put those hygienists through?
Yeah, I did. I told intro to dental.
Right, and you watch what they do to them. Measure each tooth. Where the hell you go for a dental exam when they measure each tooth? Right, yeah, but they don't do that when you go to the
No, they
dentist
don't.
for a cleaning. They dig in there like they're digging
Or
for
take
gold.
your BP either.
No, they don't do any of that. They dig in there like they're digging for gold. I'm like, does it hurt? No. You know, does it hurt? Well, if I say it's going to hurt, you're going to stop? No, then just finish. Just get in there and dig it out. What you're going to do and be done. You know, but no.
It's
Because I
actually
went there
funny you
once.
mentioned that because I had to get a root canal
Yeah.
About two months ago, and he messed up my GMT.
Oh, that's nice. That made you feel good.
I couldn't shoot for like 3 weeks.
Yeah, right. Don't you love
Because he
that?
kept on going, and I was stuck.
Yeah, they ate the wrong thing and oops. Like one time I had, they Novocaine and it killed me after for like weeks. Well, we hit a nerve the wrong way. Oh, good. So what do I do? Well, go away. Yeah, but it didn't hurt before, now it hurts. It's aggravating. It did. It took about a month and it finally calmed down. So we make mistakes. Try to make erasers. Okay, so now we go here. Now the full ventricle, the full H is going, okay? So now the H is going to depolarize and delay, and now it's going to get delayed at the AV node. This is giving time for all this blood to get here. That's why it's doing that. So now we finally get here where we're traveling down the septum to the bundle of his. Now if it was a woman, we say bundle of hers, right? No. I'm surprised that's not shown this way. Why do they call it the his? It says hers. Yeah. So we'll go here. Bundle of his and hers. Okay, so down we come. And so now the ventricle depolarizer begins at the apex, causing the QRS complex to form. And the atria is totally repolarized at this point. So, like a corkscrew working up. Makes sense. I got to push the blood from here out, not here down, here out. So I have to start at the apex and corkscrew up. And it makes sense to move this blood out. That's what's happening. Now the ventricle, we're getting here, the ventricle depolarization is complete. So it's done with its full contracting at this point in time. Now we get to the T wave. The ventricle repolarize begins at the apex. We start here, and we work our way back up, causing the T wave. So as different firing takes place, it reads it. It can see it. When they do EMGs, like on a muscle, from that firing at that point in the nerve to the muscle, that should happen in a certain latent time frame. If it doesn't, then there's damage to the nerve. If this doesn't read right, then there's damage here. And that's what they're showing you. And then at this point here, you totally repolarize the whole heart, and it starts all over again. So all you did here was trace the drop of blood from here to here. So you literally can look at that and trace a drop of blood too. So now you know even more than just tracing the drop of blood. Because you know what's happening in each phase of the way. So if I make this somewhat interesting, instead of just looking at a picture with a stupid thing next to it, it's like, yeah, big deal. I'm going to do this. I'm going to just do home key. But out of university. No? I'm not going to do that. Home care. Some of you might like this and you're going to become cardiac nurses.
How about when you learn and you get excited? Like, I want to stand up and scream?
Do it.
I mean, of course not, that's not reasonable, but
I told you, approach these classes so that you get excited as you're learning, not afraid. Fear shuts off your learning. Opening your mind and getting excited, you'd be surprised how much you retain. And the one thing I like is when you leave here and you go back and look at it, you remember. So I can stop learning. Not leave here like, what the hell? I don't remember even showing that damn spot. Where the hell was my brain? It's like you have that dream of show up for finals and it's like, why wasn't I here all semester? That's the nightmare you guys would have when you get out of college. I still have those nightmares like a million years later. Like I said, or I'm sitting in this class and someone else is teaching and I'm a student. It's like, what the hell? I teach this. Why am I a student? What did you become a nurse, I guess? So look, it tells you what's going on. So changes in patterns of disease may make disease or damage. Not like an enlarged R wave may indicate a large ventricle. It's a very loving person, very big heart. Elevated or depressed ST stomach indicates cardiac ischemia. And the reason why this doesn't work well after, because the tissue that normally should be excitable becomes replaced with scar tissue, which doesn't excite. Like old marriage, it's all scar. No. There's no excitement. Right, when you go home at night, you walk in the house, it feels like that first date you ever saw the person. Yes? Nobody's making comments on it. Right? Well, I live alone, but that's better. Okay. So problems can be, so how about a prolonged QT segment? No, Q to T, so going from, depolarizing to repolarizing my heart, this is going to create a risk of arrhythmias, because the heart, some of it is shutting, some of it is not, so now it starts beating all abnormal eventually. So it's just trying to explain to you how you look at this and figure out why this is happening, and then what is going wrong in there when this thing isn't working right. But the most important thing when you leave this course, do you remember what the normal is? Because then when you start learning your methodologies and your careers, you'll realize what's going wrong. Because I know what's supposed to be normal, but this is not. It's like driving a car. When you push the gas, it should go, not stop. Ooh, I push the gas, it stops. When I push the brake and it goes, well, that's really screwed up. You got a good mechanic who worked on it last. So there's normal sinus rhythm. That's usually what they say. So NSR, normal sinus rhythm. So there it is. So P, right? P, Q, R, S, T. And then does it again. And each block means so from usually the cycle to go from, I'm jumping ahead on you, but to go from there to there should happen in an 8.8 second wait for that totally to go through. So that blood to travel from your vena caves to your aorta should be within that window of 0.8 seconds. That's pretty quick. And just think about it. Just think about doing this as like 22, 23 days old in Europe. It's been doing this over and over and over. You're not even aware of what it's doing. So then we get junctional rhythm, meaning we have no SA node, no P wave. Where did you go, P? Can't find you. So make a joke out of it. So you remember what a junctional rhythm is. No P wave. I'm beating here. Well, that ain't doing crap. That's not going to move blood around my body. And guess what? If you go up a flight of stairs, it's still at 40 beats a minute. It's not doing anything. There's no SA node taking information to start getting this to go. So that's a good thing, walking up 3 flights of stairs and my heart stays the same. It's not even efficient at rest, so the inefficiency is going to get even worse with activity. Second degree heart block. As a result, there are more P waves than QRSs, and this trace is usually 2 P waves for each QRS. Well, look at the length of time before things are happening compared to when you went back to the normal trace. So much more rhythmic. Length is increasing big time. I'm not going to make you identify this stuff. You want to know what this is? Not that. And you want to say, it might ask you, if I'm lengthening this thing, could this be an example of first degree heart block? And the answer would be yes. You know what I'm saying? So if I lengthen that segment, but I'm not going to make you retrace things. I'm not going to get to that extreme. Let the nurses do that with you. And then fibrillator, it looks like a little kid drawing. It looks like my handwriting. My hand's in fibrillation. So, what am I going to do to you? Oh, after an electrical shock or a heart attack. Because the rhythm is all screwed up because you just screwed up the wiring system. gives you some idea when the tracing goes this haywire, what is happening to my electrical system in the heart. Okay? So now mechanical events in the heart. So systole, so blood pressure is what? Systole over the right? So usually systole means the heart's in contraction, diastole is in relaxation. So you hope that this relaxation of the heart, the pressure does come down. So there's no pressure. So that's why blood pressure is so important. So you take one on a patient that you're going to clean their teeth is 220 over 120. You're like, all right. You're going, oh yeah. You take anything for it? When I feel like it. So is that a time bomb? Yeah. Time bomb for stroke. Think of these little capillaries up in the brain with all that stress out. Around the heart. And the kids, so you can cause so much dysfunction, okay? So cardiac cycle, blood flow from heart during one complete heartbeat. You never saw a heartbeat? Wasn't there a song years ago, heartbeat? Was it Michael Jackson 5 or something? Or the, I don't know, it was the Osmonds or one of these bands from one of these family bands from the 70s. Listen to that. So, go listen to that song while you're looking at this stuff. But guess what? Then you'll remember it. Because the song will come in your head when you see heartbeat, and it's going to make sense to you. So learning to music does help. They've done a lot of studies showing that. Certain songs that fit, it's a heartbeat. So one true cycle of the heart. So atrial systole and diastole followed by ventricular, and that makes sense. We just did that, right? Cycle represents a series of pressure and volume changes. So now we're going to get into the volumetric shifts in the heart to make things move. This is what we're working towards. Okay? Yes, the excitement is killing me like earlier. So because of pressure gradients, valves will open, valves will close. And they're supposed to do that. Okay? So pretty much mechanical events, we see these on ECG. So the ECG is watching for this to be rhythmically. So that's a complete cycle. When you go from the beginning of P all the way past the T, that's a cycle. Everything went into relaxation and contraction. That's one cardiac cycle. So every time you count that on the ECG, you're counting how many cycles there are. So that's all this is explaining to you. All right. So now we're getting ventricular filling mid to late diastole. So pressure is low. 80% of the blood passively flows from the atria through the AV valves into the ventricles from the atria. So what's that cell stream? What? Semilunar valve. Yeah, not Saturday Night Live. Okay. So semilunar valves close. All right, so what it's telling you, the atria is pushing this way, and the AV valve's open. And 80% of it is passive, because of gravity, so it goes through. Because there isn't a lot of pressure. If you get to where if you're at the pressure gradient that's at the vena cava, you're almost in zero. There's not much pressure there, because it's the end of your venous line. So when these atria, so there's enough pressure that the valve opens, and the blood pours down. So one thing we want to make sure as we're in this mid to late diastole end cycle of your ventricle is that these valves are closed. Then the atria starts to polarize and triggers atrial systole. At the end is when that push happens with the atria to push that 20% of the blood down into that ventricle. So you can see the first phase as it's starting is kind of passive. It's that last 20% of blood to get out of the atria and get it into the ventricle. Now, when it gets in there, okay, so when that happens, you're at EDV, end diastolic volume. That's the ventricles of full relaxation taking in the blood. So they're full. Their volume is full. End diastolic volume. So
Is that if, I'm so sorry.
the volume of blood in each ventricle is at the end of its diastole. So before they contract, when the P wave is ending, at that point, they relax the ventricle. They both can't contract at the same time, the atria and ventricle. So what this is telling you, when the atria are just finishing, remember the lag? We have a lag. 0.1 lag. Well, the 0.1 lag is because of this. We need that lag to make sure the atria are done what they're doing and the ventricles are still relaxed to fill with blood. Because you're going to learn two things control cardiac output. One is rate, and the other one is volume. How much volume am I pushing with each contraction versus how fast do I contract equals cardiac output. So we're not going to go heavy into this. We're going to just go a couple more slides and stop. And then we'll come back to this on Monday and go forward again. Because once you grab it, it makes sense. But if you never grab it, anything else we do from this point on to figure out output of the heart makes no sense to you. The heart rate will, because that's kind of what we kind of done, but we do it again. But certain things will change volumetric change of a heart. And that's Frank Stalling's law we're going to talk about. If you've ever heard of Frank Stalling. That kind of says that every time the heart beats, it should push the same volume of blood. That's kind of what it's saying. But things can happen to change that. But in theory, that's not the part that really change cardiac output. Usually it's rate that changes. Through the nervous system, hitting the heart, slowing the heart down. That's rate. So that'll change output, the end output. Because it says, cardiac CO equals volume times HR, which is heart rate. That's your formula. So it's a pretty easy formula. But, so we want this to come. So depolarization spreads to the ventricles on this QRS wave. Atria finishes contraction, returns to diastole while the ventricles begin systole. Now, initially when they start systole, both valves are closed. Because as the pressure gradient builds up, it closes the AV valves. But on the initial buildup of pressure, the other valves are closed too, the SL valves. So it's in other words like a pressure cooker. It's building up pressure before it releases it. So we're building it up. So we're building up pressure so we have that force to blow this blood through when the time comes, okay? So we have to do that. So the rising ventricular pressure closes the AV valve, which makes sense. So this is an isovolumetric contraction phase, meaning the volume is not changing. The pressure is. Understand? We're not adding anything more to it. We're just slowly building up the pressure. We're not pressure cooking. Then the ventricles will be completely closed off. All valves are initially closed. That's why there's a lull between low. There's a lull. And that lull is these are closed. These haven't opened yet. We're building up our pressure. It's like a jet engine building pressure to blow the plane down the runway. Then they blow open the back and it blows through all the power, and now the engine has power to thrust the plane forward. So you're building up thrust here is what you're doing with this, okay? So now when it gets to a certain amount of pressure, these pressure will blow these open. So what I'm showing you, pressure gradients will control the valves. And when we do, the aorta should reach about 120 millimeters of mercury blowing into it. Then it opens. So initially, atria, the blood goes into the atrias. The atrias are just starting their contraction. They're not really there yet. The blood's already pouring down into your ventricles because the valve's opened, the AV's open. Then that last 20%, we get the P wave because it's full contract, bringing it out, pushing it through. Now, as my impulse is traveling from the SA to the AV node, we have a delay. And that delay is to give time for the atria to start to totally be emptied and the ventricles to take the blood on. Initially, the blood comes in, so the ventricle slowly starts its pressure buildup, and we slam the AV valves closed on both sides. Now I build up the pressure more and more. Finally, the semilunar valves open, and boom, out it comes, and I'm pushing the pressure gradient that's about that as I hit that aorta. 120 millimeters of mercury, which is about a 200 mile an hour force whacking the wall of the aorta over and over again. And then, following the ventricle, it's going to repolarize the T wave. The ventricle relaxes. At end diastolic volume of blood remaining in each ventricle after systole. So there is a residual left in the ventricles. That would be known as the end systolic volume. What's left after they fully contract? Then the pressure will drop, and their drop in pressure means now the pulmonary trunk and the aorta pressure becomes greater than the ventricle, the valve closes. And the ventricle now will go to its relaxed state. It's completely closed again, and nothing's going on in it. It relaxes. So you made it through your cycle of the heart. And that is referred to as isovolumetric relaxation phase. When the ventricles are totally done, totally off, that's what that is. So there's no volume, the volume is relaxed, there's no volume. Okay? So this is showing you the volume of blood that goes to the heart. And we'll get into how much it is, we'll talk about that Monday. But just try to get comfortable with end diastolic volume versus end systolic volume. End diastolic volume is when the ventricle receives the blood. And systolic volume is when the ventricle, what residual is there when it pushes it out. You follow what I'm saying? So in the diastole phase, the ventricle's relaxed, the atrius just pushed it in. Then it's going to build up pressure to slam this valve, build up pressure so I can slam those valves open, and the blood comes out because I'm fully contracted. Once I've done that, now I'm starting to back off. The pressure in the vessels around it become greater. They close the SL valves. And then I get to a point now, at the end of systole, what is left? What is the volume of that ventricle? That's all that's saying. Okay? And we stop with this. So when I ask, where do we stop? This is the slide. We'll go back to the two previous ones, run through it again, but because I like to do that just to make sure you're getting it. So what you should be comfortable with by like Monday of next week, the two graphs and the tracing. What's happening at P wave, QRS, T wave. If you know that by Monday, and the two graphs showing one the pacemaker, one is the cardiac tissue, you're in real good shape. So we're running the whole thing on CHF, why, what's happening. And that's the most common heart